Good afternoon, everybody. Welcome to this presentation by Department of Orthopaedics. Now, every building has many doors and windows. Doors and windows is for the people to enter and exit the building. Windows are for air and sunlight. In any surgery, we also make passages to approach the target area safely without having any minimal collateral damage. And for the hip, traditionally in India, people have been following a posterior or a lateral approach. This approach, the anterior approach, was popular in mainland Europe. It was being done in India for some very specific cases like pediatric hips, where we did not want to disturb the posterior vascularity. Now the same, a variant or the variant of the anterior approach has been used for adult hip for different procedures, not only replacement, but many other procedures. It has its own, and like any other procedure, it has its own advantages and disadvantages. So this presentation is going to be a discussion on that. Vikrant, please take over.
Thank you so much, sir, for the introduction. I am Vikrant Manhas, Additional Professor, Department of Orthopaedics, and you will all align with me on this, that for surgical procedure of any deep organ or any joint, we need to go through the healthy tissue. And the injury to that healthy tissue defines the overall recovery pattern of the patient, not irrespective of disease. So with this context, I want to go through today's topic, which is front door to the hip. Hip is one of the most commonly affected joints in orthopedic surgery. It has a rising surgical burden because of that. It is one of the second most commonly affected joint after the knee. If you see, it's a ball and socket joint. It is congruent joint, and primarily all these pathologies can lead to affection of the hip joint and may lead to surgical intervention following. The common procedures I want to highlight here is that there's avascular necrosis, in which the part of the head, this part of the head goes into necrosis, it collapses, it affects the overall joint and leads to arthritis and needs a surgical intervention. Second is sometimes the neglected acetabulum fractures or neck or femur fractures, which fail or undergo arthritis and need a surgical intervention of this joint. Sometimes the hip dysplasia, in which hip is affected, never formed the way it has to be formed and needs a surgical intervention. Inflammatory arthritis, like ankylosing spondylitis, seronegative arthritis, in which hip is affected, leads to arthritis of the hip. FAIs are the common conditions in which this congruent joint becomes incongruent peripherally, and there is a bone which is here or sometime here, which impinges over the range of motion and affects this joint and needs this to be addressed. Infective sequelae like TB in our India is very common condition in which the hip is joined. So all these pathologies need some kind of surgical intervention, and that's why we have 3 doors. One of the conventional and traditional workforce for us is the back door, which is the posterior approach to the hip. It is one of the most common approach in India and Asia because of the fact that we all has been trained in this. Second is common is the side door, which is a lateral approach to the hip. It is less common, but the Indians who have been trained in UK do prefer this approach and do these surgeries. But the problem is that it directly affects the major abductor of the hip, which are primarily required for the hip functioning, and that's why it is less commonly used. And the third and alternative approach is the front door to the hip. This is our story. So if you see here, this hip is ball and socket joint, but more important is that it is primarily covered with vast majority of muscles in and around, and that's why it's a deep-seated joint, and any way or any approach inside or wants to reach into that hip needs some kind of pass through these muscles. The muscles are primarily more in the posterior half than in the lateral half and then in the anterior half. So this is the backbone or the back door of our surgery. We all had been trained in this approach for many, many years and using this approach. So it's a wonderful approach. It has given all the results which we desired. It is extensile. It do everything for us. The only problem what we address here is that if you see here, this is the G max. We have to split this G max, and inferiorly we have to split the ITB. So we have to do this release, which is always essential to reach that hip, which is the external rotators. We always have to lift from the intertrochanteric area and then have to reattach it. We always have to lift this muscle, which is quadratus femoris, and we also sometimes has to release this G-max attachment of this over the femur. So it is a wonderful approach, but needs a quite a dissection before you directly enter into the hip and address the hip pathology. So cut muscle means a list of don'ts after the surgery. Obviously, we have repaired all this tissue and we want this tissue to heal again and become functional. So that's why the cross legs are avoided, not to bend beyond 90 degrees, not to sit on the floor, sleep with the pillow, risk of dislocations and slower returns. If you go through Google and just type the precautions to follow after posterior hip replacement, these are all precautions. They will pop up from all the hospitals, all the inventory, the multiple precautions which are attached to it. And the most common are this hip abduction. So you have to use this pillow for minimum of 3 to 6 months, and you have to use this pillow between the legs for minimum of 3 to 6 months, and you have to sit beyond 90 degrees of flexion. So why front door? So this is an old approach. Risk, as sir addressed, it is rediscovered for the adult hip. It's not a new invention. It has been used for centuries. It has been used by pediatric surgeons till now for dysplasias and hip pathologies, primarily to avoid the vascular injury to the hip and to avoid the growing bones and muscles. What change is it in the adults? Because as the muscle around the hip grows and it becomes more deep-seated, entering into the hip and reaching into the hip is easier, but then maneuvering the femur and managing the acetabulums become much more difficult without releasing this soft tissue cover around the hip. That's why most of the surgeons in India stay in the back or the side door. So if you ask me what is the ideal approach, it has to be intramuscular, internervous, and this is the only approach which is actually intramuscular. It goes between the two muscle groups, primarily the anterior group of the muscles, which are more or less supplied by the femoral nerve, and the posterior group of the muscles, which are supplied by the superior gluteal nerve. So it is the ideal approach, but because of the technicalities and difficulties, it is rarely used. So this is a small video. Video. ऑडियो बंद करो तो दोबारा चलाओ ऑडियो बंद करो इसको So if I'm demonstrating this approach, this is the TFL which has been retracted laterally. If you see here, deep is the tensor fascia. So if you see this muscle is retracted medially, and then you have these small vessels, which are the branches of lateral circumflex femoral artery. You just ligate those vessels or cauterize these vessels, and directly you land up into the front part of the hip. If you see here this fat, this is the fat pad, anterior fat pad of the muscle. And if you excise this fat pad, you directly land up into the joint. This is a retractor which has been placed superior to the joint. And the next retractor is placed inferior to the joint. And the anterior group of the muscles are retracted. This is the fat pad which is present in front of the hip joint. So this is the rectus femoris which is retracted anteriorly. And you can see the hip joint beautifully. And you open the hip joint and you can address the pathology. So there is no muscle which has been cut. If you see my hand, there is no blood till now on my fingers. The tissue planes are completely avascular because we have not dissected any muscle. You open the hip capsule and you directly enter inside the joint. So we started this approach in 2022 in our department. We started with pretty straightforward for the hip replacement surgeries. And we extended into our hip replacement surgeries for quite a long. And the incision size just significantly reduced, like around 6 to 7 centimeter, which earlier used to be 18 to 20 centimeters. There was no dissection of the muscles. It was a very soft window in which the hip replacement can be done. You can see there is a big implant which has been placed through this very small window. The results were very appealing. If you see here, the patients are cross-leg sitting, squatting, all the precautions which are attached to the previous approach has been taken care of. This, you see this boy, this is just 2 days after surgery. He's telling about मेरी hip replacement surgery हुई है, I can do whatever I want to do. So this is patient right now with us in the private ward. So there are no restrictions to the movements, no restrictions to the abduction, adduction, and internal rotation abduction. He is free, he is pain-free, and is moving his hips like no surgery has been done. So one more patient, next day after surgery, getting out of the bed by himself after hip replacement surgery, moving around with the minimum assistance. Our resident is helping him. Another patient, there is, you can see here, the drain has been put after the surgery, but he's pretty comfortable with overall because all the soft tissue around the hip has been retained. There is no collateral damage to the soft tissue around the hip, and that's why the patient is relatively pain-free. So this is today clicked by Mohit. This is immediate follow-up after 3 months. He came today, just see his movements like nothing has been done. He is squatting, cross-leg sitting, just nothing has been done. The recovery is wonderful. And we extended this approach to more difficult cases, like acetabular revisions, in which any other approach has been difficult. Like patient, but the recovery pattern was more or less assuring. This is at 2 weeks, and this is at 6 weeks from his home. Then even more complex cases like this, dysplasias. If you see here, there is no neck. The head is directly articulating with the intertrochanteric area, and the space between acetabulum and the intertrochanteric area is very minimal. These are the cases which are even difficult with the other approaches as well. But if we extend this approach, we can get excellent radiological outcomes and even the same outcomes which we're getting for the primary hips, straightforward hips. He's sitting on a low chair, adducting, no precautions. At 6 weeks, you can see his happy face that he is completely pain-free and recovering well after surgery. So what we got from this approach was a surgery with precautions to the surgery with no precautions. But we have addressed only till now the hip replacement arthritis. But there is a spectrum of pathologies which need to be addressed, like what about the complex primaries or complex conditions? What are the revision surgeries? Can we do this approach, extend this approach to the revision surgeries? And can we have these same benefits of early recovery after these surgeries also? What about FAIs and synovial chondromatosis, where we don't have to replace the joint, but actually we have to preserve the joint? Can we extend this approach to these conditions also? So for this, you need another retraining of doing an extensile approach. That's why we visited multiple universities primarily in Europe, and then extended this approach to the complex cases like these, in which we primarily use posterior approach. The results were more or less wonderful. Like these cases, which are only done at AIIMS, I think, nowhere in North India or India need to touch these cases, are very complex cases. There is aseptic loosening of the implant. The surgery was done around 25 years back. There is a protrusio. There is complete lysis of the acetabulum part. The head has gone inside. Very complex surgeries. But we extended this approach to this. Not only this approach offered us early recovery, but also the supine position because of this approach offered her to incorporate the C-arm into it. Now we can reconstruct this acetabulums in a supine position under the C-arm guidance, which was very difficult with other approaches because patient was always in the lateral position. So the easy reconstruction, and these are the 6 months follow-up. So extended same approach for the other patients for the similar conditions, failed THR. Same C-arm supine position was used to reconstruct under the image guidance. And these were the x-rays. And if you see here, she is immediate post-op, drain, Follies, next day in the morning, smiling. 2 days post-op, discharged, 2 weeks post-op, 4 months post-op. So even with very complex surgeries, these tissue planes and less violation of tissue planes were giving us the results what we desired from the primary surgeries also. So this need a special mention because for the spine and hip, this was the only joint which was mobile and it has failed now. Hip is fused, the whole spine is fused, and more important, he is a younger brother of our sister in charge for the OT. She showed the confidence. She wanted us to replace this joint with a direct anterior approach because the early recovery was very fast. So we did the same for her. Under C-arm, complete acetabular reconstruction, and he was happy early morning in the surgery. So till now, we have extended this approach to very simple and complex surgeries of the hip replacement, but we have not used this approach for the condition in which we want to save the hip. Like what about the other conditions, FAIs, because of vast spectrum. So little mention about the FAIs. So if you see here, this is the normal ball and socket joint where the socket and the ball is more or less congruent with each other. But if you see here, this is the line. This is the extra bone which is extending at the margin of the femoral head. Whenever the hip flexes, this impinges over the acetabular area and the reason for pain. If you see here on the CT scan, this small bump here, this is the pain point. Whenever the hip flexes, this impinges over this area and causes the pain. So primarily these FAIs are done by this approach, safe surgical dislocation of the hip. So because we have to maintain the blood supply for the femoral head, we don't disrupt this space because from here the blood supply enters into the capsule. That's why what we do is we do an osteotomy of the greater trochanter. We dislocate the hip anteriorly, we shave off the hip, and then we fix this greater trochanter with the pins. So we are doing our job just like we were doing before, but even more restrictions. Now the weight bearing has also been restricted because we want this bone to unite. So we extended this approach for these patients and we call it as a hybrid arthroscopy and mini open DA. And we open up a very small window anteriorly. We directly under the eye address this a bump which is on the femoral head, and the acetabulum is addressed by the dry arthroscopy. And then because there is no need for the trochanteric osteotomy, we expect the early outcomes. And what about the synovial chondromatosis in which we need to dislocate the hip? So these are the conditions in which we have to address the circumferentially the hip joint, primarily done by the safe surgical dislocation. So in this, you can dislocate the hip, you can reduce all the disease burden this joint have, get a complete clearance, and you can re-dislocate the hip without doing a trochanteric osteotomy. So this is the paper which we published here, which was a mini open direct anterior and hybrid arthroscopy. So what we have gained so far, it's the same conditions, but the life without the don'ts. So what this approach offered is all the crosses, which we used to say that no cross-leg sitting, no floor sitting, no Indian toilets, constant guard against dislocation, long list of things to avoid, has been ticked now. You can do whatever you want now, do, but how Indians live is actually, this function is actually not a luxury. It is the day-to-day functioning of this hip. The difference we make with this approach is not a replaced or restored joint, but actually a restored life. This is actually restored the function of the hip. But does it really make a difference? This is the only Indian data. It is a limited data. It's a new approach to India. But what about the literature which has been published worldwide, like in Europe and now from US? So all the study says the pain reduces. So definitely pain is less comparing to any other approach. 24 hours, 48 hours, 72 hours, pain is much less than any other approach for the hip. The function is better for initial 3 to 6 weeks, but all the approaches converge to the same endpoint. The function becomes plateau after 3 months or 1 year of the approaches. the hospital stay is less, the transfusion is less. So if we go back by the literature says that the improvement in the function with the direct anterior approach or the anterior approach or the front door is limited to 3 months comparing to the any other approaches. But this is very important data which I really want to address here is, I'm following this for the last 5-6 years now. This is the Journal of Orthoplasty, one of the most reputed journals we have for orthopedics. This is annual conference they have every year, American Association of Hip and Knee Surgeons. Whatever data they retrieve from that conference, they do some kind of data interrogation to identify the current practices of the arthroplasty, and they publish it every year. So since 2019, they are publishing every alternate year, and they want to signify what is the change in the trends in the approaches to the arthroplasty. We were more focused on the hip. So if you see here, it's a very different data from rest of the world, because this lateral approach, the lateral door hasn't reduced. It was never a popular approach. But the posterior approach, the back door, which was used to be popular in 2009, around 65% of the surgeon used to do this approach, has declined to 30% in 2024 now. And the direct anterior approach, which used to be in 2009, 12%, now has reached up to 65%. And we entered somewhere here in India. So we will follow the same trend. We are with direct anterior approach in India, we are somewhere here, just like other countries, maybe around 8 to 10%. And our main horse approach is like posterior approach or posterior order 65%, and we will follow the same curve in the following years. So seeing is believing. We believe that the patients have improved outcomes with this approach. Functions are better. Literature also says that. But literature also says that after 3 months, there is no difference in the function. So what we try to understand with radio diagnosis, with a collaborative program or a project with a radio diagnosis, that let's do an MRI at 3 months and 6 months and understand, are there any sequelae of muscle damage which can be seen, which can be predicted at 3 to 6 months MRI post-surgery. Although the instruments are man-made, there are certain limitations to the functional limitations where we identify or we calculate the function. But is there any difference in the muscle damage pattern or the sequelae of the muscle damage pattern between the two approaches? So I'd like to invite Dr. Ankur Goyal from Department of Radiodiagnosis to shed some light on it.
So we analyzed few MR scans of these patients, which were done 3 to 6 months after the surgery. Anatomy you all know, and you are all aware of the Gutalier classification, which is based on the amount of fat infiltration into the muscle. So these are just sample cases where we can see. So if we compare the piriformis on both the sides, so this side is the operated side. So there are subtle streaks of fat, but it is reasonably fine on the operated side compared to the other side. On the other hand, this is a patient who was operated using the posterior approach, and we see there is marked atrophy of the piriformis on the right side compared to this bulk. And even in that, the amount of fat component is more. Similarly, here we can see, so this is the direct anterior approach patient, and we can see the quadratus femoris, which is convex. It appears reasonably okay in bulk. Compared to the posterior approach, where there is more than 50% fatty infiltration, the muscle is flattened and it is concave. So we analyzed some patients, and we could see that the patients who had undergone direct anterior approach showed better muscle bulk and lesser degree of fat infiltration, especially in the posterior compartment muscles. So in the anterior compartment, we could see that although this was an anterior approach, but even then there is no significant damage to the anterior compartment muscles, and the muscle bulk and everything was comparable in both the situations. Thank you.
So on MRI also, it suggests that it preserves both the compartment of the muscles, both anterior and the posterior compartment. So this is the journey so far for our approach at AIIMS. So we adopted in 2020. It it was the earliest institutional programs. We were the early adopters of this approach. Till 2022, we had a learning curve. The patient selection was limited. The team was small. The instruments was also difficult to find. And we somehow did our first 50 cases. And that we published in Hip and Pelvis in 2024 after 1 year of follow-up. In 2023-24, we retrained ourselves and tried to extend this approach to more complex cases. And by that time, this approach has become a default for us for the primary hip arthroplasties. If you see here, 2025, we have published papers on complex cases like bony ankylosis, a systemic review, a meta-analysis on the Asian demographics. We were able to find hardly 1 or 2 papers from India and rest of the papers from other countries of the Asia. And they also suggested that the results are more or less aligned with the Western literature, that early results are better. 2023, 2024 was the time when the further it was extended into the other approach, other indications in which these new papers come out. And 25, 26, it extended to the FAIs and the muscle sparing research underway. And by now we have done more than 500 cases, extended to all the possible indications for the hip, including hip preserving and hip replacing. And these are the few papers which are under review and under press. We also were the first to do a 2 days program, which was primarily dedicated to this hip replacement or this approach, and trained our fellows, interns, and all surgeons across India. It was first of its kind and in line with the conferences which are done for the same approach worldwide. Also, the first as a guest editor, first journal or first special issue, which is primarily dedicated to this approach. And we try to populate all the possible research which is happening in India and worldwide. So by this, so where we are right now, we have integrated the robotics into it. We have widened the indications. We are training the fellows and residents. We are doing research and leading the research. All the data which has been published so far I have shown you is data which has been populated or collected from AIIMS only. Academic leadership, we are targeting conferences, we are running a special issues, and more important is patient first care. We are primarily focusing on the early recovery of this patient because patients are relatively young. And 3 months of the patient is also mentioned, also matters. So 3 things to carry home are, so the approach, how you reach the hip decides the collateral damage before you even touch the patient hip pathology. Front door anterior approach spare muscles, you can see on the data published and also can confirm on the MRI. This means fewer restrictions and the faster recovery. And if you can see these Indian patient doing Indian things, we'll be more than happy to see. Thank you. Any questions, sir, ma'am? Thank you, sir. Thank you, sir. Yes, sir. Thank you, sir.
Approach, or is it because of the disease in itself? Because primarily these are hip arthritic patients, right? They may not be using those muscles anyway. Do you have like a pre-op versus post-op?
Doing that.
Okay.
That you are absolutely right that it would be better if we compare the pre-op with the post-op, because some of these patients actually have pre-op because they are not using that
Particular.
So I want to primarily mention about this, which is under review with the arthroplasty today. So it is with 2 setups for the same approach, with the traction table and with the standard table, in which we have seen pre-op, post-op improvement and also post-op improvement between the 2 groups. So MRI was compared from the pre-op to the post-op and the post-op for the 2 groups also. And there is a significant difference in the 2 approaches. Thank you, ma'am. Yes, ma'am. Ma'am, this evidence is there with the Western literature that Yes, our patients do recover early. The papers which we have published is that hospital stay has reduced from 3 to 4 days to 1 or 2 days. The analgesic requirement has reduced. They usually don't take any analgesics beyond 7 days or 10 days. They're in the papers, ma'am. Yes. Yes, ma'am. I have shown few cases also. Their vision orthoplasty cases. The section is definitely more, but the restrictions are less. And the if the patient has less restrictions, we expect the patient recovers faster. Yes, ma'am. Definitely, if you cut muscle, yes, if you cut muscles, if you go through the fibrous planes, if you go through the planes which has been used before, they bleed more. If you go through the fresh planes, new planes, and don't cut the muscle and dissect between the muscle planes, you bleed less. Supine for you also, ma'am. Yes, 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 sir. Yes, sir. Sir, any comments, sir? Yes.
Tissue damage and doing all the work.
Yes, ma'am. We can see in the MRI also, all the anterior muscle and posterior muscles are preserved.
Just few words actually. Change is the only thing which is permanent in this world.
Yes,
So
sir.
everything changes. It started in Western world.
Yes, sir.
Gradually in our country also, this will definitely grow. And we are fortunate enough. Congratulations to you. And thanks that you started this. Obviously, it will grow up. Keep it up.
Thank you, sir. Thank you, sir. Dr. Molnar came in 18, sir. Thank you, ma'am.